I'm Dr. Ron Berkman. Today we'll be talking about postpartum hemorrhage with a focus on the evaluation and medical management. Upon completing assigned reading material, viewing 2 videos, as well as participating in the follow-up session, participants should be able to discuss the following as it relates to postpartum hemorrhage: the diagnosis and etiology, the evaluation, factors which decrease the safety for women when they have this complication, clearly the medical management, as well as secondary invasive approaches. So what's the rationale for developing a toolkit? A toolkit for postpartum hemorrhage would include things like algorithms, protocols, training exercises, perhaps a cart to contain necessary medications and supplies, all of which is important to the management of this particular complication. And it's important because postpartum hemorrhage complicates 3 to 5% of deliveries. The rate has increased over about 25% due to increased rates of apnea. Certainly postpartum hemorrhage accounts for about 10% of maternal mortality in the United States. One group that has focused significantly on this issue is the California Maternal Quality Care Collaborative, which is a statewide group involving multiple hospitals that do obstetrics, as well as experts in the field of epidemiology and in obstetrics and gynecology, as well as other fields related to trying to manage complications such as these. And if you look at, again, other data, you can see that, for example, when you look at maternal mortality and you look at the percentages of various causes, you can see leading cause is in fact at about 17.5% is apnea. And this is followed fairly closely by abruption and by laceration. So again, apnea, which is a major cause of postpartum hemorrhage, is also a significant player in maternal mortality due to hemorrhage. So we need this toolkit because the incidence of obstetric hemorrhage is increasing. Also, when you review hemorrhage-related deaths, they generally have a high rate of what we call preventability. And when these reviews are carried out, it indicates breakdowns at multiple points. Many of these breakdowns are under our control as opposed to those who are not under our control. For example, in a review of 108 maternal mortalities in North Carolina, if you look at hemorrhage, it accounted for about 14% of all these deaths, but 93% of these deaths were felt to be preventable. So it is an area that can be impacted by what we do as care providers. In addition, when you looked at, or when the group in the California Collaborative looked at maternal mortality in California, they noted when they examined obstetric hemorrhage, there is a strong to good chance that the outcome could be altered in about 70% of cases, and to some degree in another 25% of cases. So again, it is a complication that should be able to show some decline with proper management. Some of the key findings in 2008, around the time this survey was done or just after, was that 40% of hospitals did not have a hemorrhage protocol. There also were inconsistent definitions of hemorrhage across all these hospitals in California. I think this was based on about 170 hospitals. 70% of the hospitals were not performing drills, and when they did do drills, physicians were not regularly participating. Most did have access to uterotonic agents, so medications were not a significant issue. However, many hospitals reported they did not have access to some of the so-called non-medical or non-medicine related techniques, such as Bakri balloons. So let's look at definitions. How much bleeding is too much, or how much hemorrhage is too much? Certainly, some of the standard definitions have said that postpartum hemorrhage for a vaginal delivery can be defined when it's greater than 500 milliliters, and for a cesarean delivery, more than 750 milliliters. Well, in actuality, 500 milliliters of blood loss is average when one takes the time to do accurate measurement. as well as 750 milliliters for a cesarean delivery. And for the most part, this amount of blood loss is well tolerated by women. The World Health Organization defines estimated blood loss of greater than 500 milliliters as an alert time for physicians to, as well as other care providers, to start thinking about other approaches to management other than those that are routine. And clearly, when there's been 1,000 cc blood loss, one really has to take action to reduce a continuing hemorrhage. It's also important to recognize, as shown here in the box to the right, that 1/3 of women with more than 1,000 milliliters of blood loss have no risk factors for it. American College of Obstetricians and Gynecology, and sort of re-looking at various definitions, now feel that an estimated blood loss of more than 1,000 milliliters or 1 liter for either vaginal or cesarean birth does require enhanced surveillance and clearly early intervention, and as needed, actually, before it reaches that degree of loss. And it's also important to keep in mind that 4 to 5% of women who deliver or undergo a cesarean delivery will have a blood loss that will be in the 1,000 cc's or 1,000 milliliter range. So what's the etiology of postpartum hemorrhage? Well, you have primary and secondary causes. Certainly high on the list on the primary causes are uterine atony, but one also can have lacerations, retained placenta, abnormalities, particularly as they related to the so-called placenta accreta syndrome. You can have defects of the coagulation due to DIC or because of pre-delivery issues, as well as uterine inversion. Secondary causes include subinvolution of the placental site, and again, the bleeding with this would occur sometime after, usually most women are discharged from the hospital or the point of care. There can be retained products of conception. You can have bleeding related to infection, as well as bleeding related to inherited coagulation defects. So if you look at risk factors for the primary problems in this, we look at atony. An atonic uterus can be due to prolonged oxytocin use, a woman with high parity, the occurrence of chorioamnionitis, or even the use of the general anesthesia. Also, an overdistended uterus, as seen with twins or polyhydramnios or macrosomia, also can be an etiologic issue or risk factor, shall we say, for atony. You can have fibroid uterus where the contractile pattern is not adequate. That also can produce atony. And finally, uterine inversion also. And the risk factors would be short cords, excessive traction trying to remove the placenta, as well as a fundal implantation of the placenta. Genital tract trauma also can lead to hemorrhage, and this can be due to episiotomy, other sorts of lacerations, cervical rupture, and risk factors certainly would include an operative vaginal delivery or precipitous delivery. Retained placenta or placenta accreta are certainly issues, and retained placentas would include things like succinuric placenta or previous uterine surgery or incomplete delivery. And again, suggesting clearly inspection of the placenta is one of the issues that or procedures that one should carry out following any delivery. And finally, you have abnormalities of coagulation. These may be related to preeclampsia, inherited disorders such as von Willebrand's, severe infection, rarely amniotic fluid embolism, and sometimes in the course of a treatment of a severe postpartum hemorrhage, it could be due to excessive crystalloid replacement. And again, this may be risk factors may be signs of abnormal breathing, petechia, certainly fetal deaths, abruption. All these various issues can be risk factors for abnormalities of coagulation. Once you have a patient coming in, again, you need to keep in mind that postpartum hemorrhage is not always predictable, and not all women, as we've already indicated, will have risk factors. Therefore, there's a need to have a risk assessment that allow one to make a decision as to how to deal with having blood available should a hemorrhage occur. So those who are, shall we say, of low risk would have had, for example, no cesarean deliveries in the past or other types of uterine incisions. The pregnancy, the current one, should be a singleton. They should not have had multiple high degrees of multiple deliveries in the past, certainly should have not had any bleeding disorders or a history of postpartum hemorrhage. So those particular patients, one can send a clot off only to the bank and probably does not need to have a type and screen or cross-match performed. You then move on to women who have prior cesarean births, multiple gestations, patients who've had 4 or more deliveries and the like. All of these sort of put you into a medium category where you would do a type and screen. And finally, you have high-risk patients, those with previous, those with suspected placenta accreta syndrome, those who are significantly anemic or have low platelet counts or show already some active bleeding and may, in fact, be experiencing a coagulopathy. Those patients clearly need to have blood cross-match. So when you look at how you classify women, and this is based on the California approach, stage 0 is basically a patient coming in. At that point, you do the risk assessment that we just discussed. Once they deliver, you have active management of the 3rd stage. That's the use of medications like oxytocin and prompt delivery of the placenta, perhaps after a short time waiting to allow the blood flow to be increased to the fetus. And also it does require that you do some antepartum counseling, particularly for those individuals who do have risk for the placenta accreta syndrome or who are Jehovah's Witnesses, who aren't very likely to receive blood products, as well as those with anemia. You do your best, obviously, to correct it. Certainly, based on how you classify them, the appropriate specimens must be sent to the blood bank. And a critical factor in all of this is the need to quantify blood loss for all births. And this is not done well in many institutions. And here is data, or let's see, a protocol, shall we say, from a committee opinion published a year or so ago. And they really clearly point out in the committee opinion that visual estimates are not very accurate. So what's suggested is that pre-delivery fluids, such as amniotic fluid that's in buttock drapes or in canisters in the OR, be removed immediately after delivery. And then you tabulate blood loss in these types of collection drapes after the fluids have been removed. You then weigh all blood-soaked sponges and lap pads and subtract from those weights the known dry weights from the soak weights, noting that 1 gram is roughly equal to 1 milliliter, and then you summarize the totals. Again, it takes training and a focus on this type of detail, but once it's done, one has a much better feel for how much blood loss is occurring at a particular delivery or cesarean delivery. You then, after you sort of be prepared in stage 0, move to where, in fact, there is some evidence of postpartum hemorrhage. So stage 1 in the California approach would be blood loss greater than 500 with a vaginal delivery, or 1,000 with a cesarean delivery, or changes in the vital statistics, or signs rather. A heart rate over 110, blood pressure showing clearly some dropping in both either systolic or diastolic, and the patient continuing to bleed. And when that occurs, you activate your hemorrhage protocol that you have, including a checklist to be sure things that are needed are there. At this point, one would assume oxytocin has already been provided. Therefore, you go to a standard second-line medication for treatment of atony. And it's also important that you prepare for a continuing problem. You make sure that there's an iron at bedside, but you also get help. Make sure that the intravenous access is at least 16 gauge. You make sure there's a Foley catheter in with a urimeter just to keep track. And you must have a type of cross match for at least two units and continue to quantify the blood loss. If you look at the medical management, you can see that the first line is oxytocin, given intravenously as shown here. If for some reason the patient comes in with a very rapid delivery and does not have intravenous access, you can give oxytocin 10 units IM. Important is that you should not do an IV push of oxytocin, since this can result in hypotension, which in many instances is hard to reverse. The secondary agents, when this is not working and you're in the so-called category 1, would include things like methergin, as shown here. Certainly patients with hypertension and preeclampsia would not be candidates. One can then use, or instead use, things like Hemabate, as shown here, as well as misoprostol. And this basically sort of outlines these recommendations that we just went over, showing that you would do the rapid infusion of oxytocin and then add methergin, misoprostol, or Hemabate, as we just discussed. There is a new agent that has been looked at not only in postpartum obstetrics, but in other areas as well, and that's tranexamic acid. It is an antifibrinolytic agent that can be given intravenously or even by mouth. In one randomized clinical trial of over 20,000 subjects across the world, and you compare the drug to placebo in addition to usual care for postpartum hemorrhage, it did show what I would say a modest improvement in maternal mortality, but only if the drug was given within 3 hours of the onset of the hemorrhage. And so at this time, I would say it's relatively experimental, at least in this country. It is certainly a consideration if the initial agents have failed, and it's a consideration if there is a substantial hemorrhage, and again, its use can be done early. One example, when we discussed briefly having the so-called toolkit, is preparing an obstetrical hemorrhage cart, which one could store, for example, in the operating room. This would include materials for starting additional intravenous sites, would be pressure bags for intravenous solutions, sutures for use in the various tamponade procedures like the B. Lynch procedure, also instructions in how to do these procedures, and instruments for inspecting the vagina and for repair of things like cervical lacerations. And it would also include packing as well as a Bakri balloon device. This is certainly something to be considered, as opposed to looking at various areas in supplies room trying to find these various agents when you most need them. Once we get out of the first stage of hemorrhage, we then enter the second stage. And here, the clear thing, if you look at the middle part of the chart and the first red, shall we say, writing, delay is critical to be avoided in this stage, because at this point there's been substantial loss, usually more than 1,000 cc's, but again approaching 1,500 cc's of cumulative blood loss. If it has not already been done at this point, and I'll go back, sorry, one should certainly rule out other causes, and this would include whether it's been trauma or lacerations, whether there's a retained placenta by inspection, as well as at cesarean delivery, whether there is also trauma there, such as an extension, and certainly be sure that one has not missed a uterine inversion. But as you look through this whole list, you can see that there's additional activities from the standpoint of the team leaders and the primary nurses, and it does require that one get a second nurse to assist and make sure that one has alerted the blood bank that there may be a need to utilize increasing amounts of blood products. This is important, and I think to keep in mind that the use of small gauge intravenous access is not helpful, and that at this stage, when you're having this degree of bleeding, you need to use the bigger gauge needles, such as a 14 gauge or a 16. And you can see that with those types of needles for access, the gravity flow is substantially improved over, say, a 20 gauge or 18 gauge needle, and the flow that you can achieve with a rapid infuser also is substantially improved. Finally, you have what's known as stage 3 hemorrhage, and this is where someone continues to bleed. The estimated blood loss is over 1,500 cc's, and more than 2 units of packed red blood cells have been given, or there's vital signs instability. Here's when you would essentially turn to a massive transfusion protocol. And essentially, you simplify it. And here you would be giving packed red cells and fresh frozen plasma in a 1-to-1 ratio. In terms of improving any suggested coagulopathy, or it is the rapid use of the fresh frozen plasma, which is probably as important as the ratio. So at this point, when this is available, you try to get those products in rapidly, followed by packed red blood cells. In terms of platelets, you would consider giving a pack of platelets after approximately 4 to 6 units of packed red blood cells. And you, at this point, must give strong consideration to moving to invasive surgical techniques, since less invasive techniques may not have been working. Now, from the standpoint of this California Collaborative, their transfusion guidelines do suggest clearly to move forward doing resuscitative transfusion, not based on labs, but on the clinical picture. And if you do not have packed red blood cells that have been cross-matched, use on-cross packed red blood cells if they're available. And the goal will be to do the 1-to-1 massive transfusion protocol roughly after the first 2 units of packed red blood cells have been given. And these are based also on guidelines by the American Society of Anesthesiologists. What you're trying to avoid by not delaying giving the appropriate products during the course of trying to mitigate the postpartum hemorrhage is to avoid substantial dilution with use of too much crystalloid and packed cells, which are devoid of clotting factors. And this becomes a serious problem when between 1 and 1.5 amount of the total blood volume has been replaced. Another issue oftentimes that's not addressed is hypothermia. And certainly such patients experiencing this degree of hemorrhage should be kept warm as much as possible, because the hypothermia decreases platelet functions, even though the platelet counts may be normal. And you're also clearly trying to prevent acidemia, which can occur with massive hemorrhage because of the hypovolemia and peripheral tissue hypoxia. Once you develop metabolic acidosis, it may be exceedingly difficult to reverse. So, in summary, what we tried to do here is talk about first-line management and assessment of women with postpartum hemorrhage. Certainly, initial risk assessment and well-delineated responsibilities of the care team members is important, and that's the so-called having a toolkit available. The toolkit is not actually something you're carrying, but is all the protocols, it's all the assignment for teamwork, but also can include a cart for supplies. All of this is an effort to be able to manage this particular complication efficiently and effectively. Certainly, the quantitative assessment of blood loss is important. And as I already mentioned, the cart is one thing to be strongly to be considered. And finally, It does, because of its complexity, oftentimes, it does help to have simulations that involve all team members, including the physicians. By doing these and doing these with various members of the care team on an obstetrical unit, will facilitate the ability for them to respond in a timely and appropriate manner.